My name is Sarah Daugherty. I'm a program officer at the Patient-Centered Outcomes Research Institute. I conducted this research as a postdoc fellow at the National Cancer Institute in collaboration with our colleagues at the Fred Hutchinson Cancer Research Center. We report in this article on a validation study that was evaluating the accuracy of self-reported prostate cancer progression. We show results from two cohorts. The first cohort identified men with clinically localized prostate cancer from the prostate, lung, colorectal, and ovarian cancer screening trial. The second cohort, which was developed by the Fred Hutchinson Cancer Research Center, identified men with prostate cancer from the Seattle Puget Sound population-based tumor registry. In order to assess progression events, we asked participants about three primary questions with respect to their recurrence, their metastasis, and any additional treatment they may have received after their initial surgery and/or radiation. Progressive events were then verified in medical records, and those events that were identified in the medical records were considered to be our gold standard for the validation study. So we compared the self-reports to the events in the medical records, and then we calculated the sensitivity, the specificity, the positive predictive value, and the negative predictive value. And we have three results we'd like to highlight for you. First, multiple questions about different aspects of progression overall performed better than any individual question alone. Second, positive self-reports may benefit from additional medical record confirmation to reduce the number of false positive reports. Third, the negative predictive value was very high in both cohorts. So if a man reported that he did not have recurrent disease, in over 90% of the cases, he truly did not have recurrent disease according to the medical records. So this would suggest that additional medical record confirmation for negative cases is not a good use of your resources. There were some limitations to our studies. First, even though we had two studies, the sample sizes were relatively small. So we were not able to evaluate reasons for heterogeneity in the self-reports. Second, it's possible that we may have missed some prostate cancer progression events in the medical records because either the medical records were incomplete or the events were not recorded in the medical records that we reviewed. Despite these limitations, we feel that our findings suggest that self-reported prostate cancer progression is an accurate approach to ascertaining a man's cancer status. Our data suggests that a two-tiered approach may be appropriate, where an investigator ascertains prostate cancer progression through self-report and then follows up only those positive self-reports with medical record review. We feel this may be the most efficient use of your resources to update your epidemiological cohort. Thank you for your interest in our article. It will be published in the May 2020 edition of Epidemiology.